I'm Sally Rosengren from Royal Prince Alfred Hospital in Sydney, Australia. I'm going to talk you through seeing a patient with vertigo. This first module will cover the essential vertigo history. There are 5 key categories of questions to help you reach a diagnosis. These relate to presenting symptoms, timing, triggers, associated symptoms, and morbidities and medications. Try to establish the main presenting symptom. Spinning vertigo is more commonly associated with vestibular disorders. Dizziness, swaying, tilting, rocking, and lightheadedness are non-specific symptoms seen in association with migraine-related vertigo, anxiety-related vertigo, and non-vestibular causes such as low blood pressure and medications. A fainting sensation is also common in low blood pressure. Imbalance and frequent falls can be multifactorial. Think of vestibular, central, hemodynamic, and peripheral nerve musculoskeletal causes. Here are the key questions regarding timing. Is this the first attack? A first prolonged attack could be an acute vestibular syndrome. Recurrent symptoms, in contrast, imply a benign cause, as do symptoms that have been present for months or years. What is the duration of the attack? BPV, for example, lasts only seconds. Establish the number and frequency of episodes. Increasing frequency or severity should raise suspicions of TIA. Ask about the duration of attacks. BPV usually lasts seconds and less than a minute. Meniere's disease is characterized by intense spinning vertigo attacks lasting minutes to hours. Vestibular migraine can last minutes to days. And vestibular neuritis and stroke produce continuous vertigo lasting days. Next, we ask about triggers. Vertigo can be spontaneous or triggered. Vertigo or dizziness that started while sitting still, for example while watching TV or working on the computer, is spontaneous vertigo. Vertigo triggered by positional changes like getting out of bed, turning to one side in bed, or bending down is positional vertigo and is most often BPV. Dizziness triggered by postural changes like moving from lying to sitting or from sitting to standing suggests orthostatic hypotension. There are 3 main groups of associated symptoms to seek. These are auditory, migraine, and neurological symptoms. A new onset of unilateral hearing loss, oral fullness, and tinnitus, time-locked with the first ever attack of vertigo, should raise suspicion of a labyrinthine stroke. Recurrent episodes of vertigo with fluctuating auditory symptoms are suggestive of Meniere's disease. A past or current personal or family history of migraine headaches or other migraine features in the context of recurrent spontaneous dizziness could be indicative of vestibular migraine. Vertigo attacks in vestibular migraine may or may not be associated with headache during the attack. Associated neurological symptoms are indicative of central nervous system involvement requiring urgent action. These include an altered level of consciousness or focal neurological deficits such as double vision, speech disturbance, hiccups, weakness or numbness, or visual blurring. Identify relevant medical conditions that could be related to dizziness, for example, nutritional deficits, atrial fibrillation, or diabetes-related hypoglycemia. The presence of multiple vascular risk factors should lower your threshold for considering a vascular etiology and for organising imaging. Non-specific dizziness can be caused by certain groups of medications, like anti-epileptic drugs, benzodiazepines, antidepressants, and antihypertensives, which could cause orthostatic hypotension. Newly prescribed drugs, recent dose adjustments, or withdrawal could all be potential culprits. Armed with the information we've obtained, we then try to identify the vertigo syndrome. Is it a first episode of severe prolonged vertigo or acute vestibular syndrome, like vestibular neuritis or posterior circulation stroke? Is it a benign recurrent vertigo syndrome, like vestibular migraine, Meniere's disease, or BPV? Or is it a form of chronic persistent dizziness, like chronic vestibular conditions, anxiety or depression, or a nutritional or metabolic problem? Remember that all of the above are treatable, but must first be identified correctly. Finally, remember the red flags alerting you to a dangerous cause of vertigo, like stroke, a first prolonged episode, crescendo vertigo, or focal neurological symptoms. A correct history will lead the way to better diagnosis and treatment.